patient decision, contrast-enhanced mammography, and extent of disease. When using the different imaging modalities, breast imaging radiologists must be able to fulfill two essential jobs. They must be able to select the most suitable imaging modality for every clinical scenario, and they must be able to provide competent interpretation and reporting. The current breast imaging modalities play a vital role in supporting clinicians in the primary diagnosis, in treatment selection, and in treatment progress monitoring of the different breast lesions. And as breast imaging radiologists, we are first asked to screen or to detect for breast lesions. And when lesions are identified, we are asked to characterize these lesions, whether benign or malignant. And when malignant lesions are diagnosed, we are asked to stage these lesions or to say whether they to do a systemic or a local staging. And what we are concerned with in this lecture is the local staging of breast tumors. And for local staging, we are asked to assess the size of the lesion, the extension, the multiplicity, and the lymph node. And we are going to discuss these 4 points from the perspective of the contrast-enhanced mammography. And we'll start by assessing the lesion size. The lesion size is expressed as T, and that means how big the cancer is. Primary tumor size is the single most important prognostic factor among women without lymph node disease. And studies demonstrate that with increasing tumor size, recurrence of breast cancer at distant sites is more common and the overall survival is reduced. In unifocal breast cancers, the largest diameter of the tumor is reported for the TNM staging, but in multiple tumors, the largest diameter of the largest tumor focus is reported.
This is okay, Rasha, but can you tell me how do we classify the T stage of breast tumors?
Yes, for the T, we say we have a T0 if there is no evidence of primary tumor. A Tx is a tumor with size which cannot be assessed, and TRS is for the presence of DCRS. But for invasive cancers, we say we have a T1 tumor when we have a tumor which is less than 2 centimeters. A T2 tumor is a tumor between 2 and 5 centimeters. T3 is more than 5 centimeters. And the T4 tumor is classified into A, invading the chest wall, the skin, B, C is invading both, and D is an inflammatory breast cancer.
Okay, but why it is important to know the T stage?
I think it's very important, Dr. Ma, because for a T1 and a T2 tumor, the patient can undergo upfront surgery, and this surgery is usually a conservative surgery. For a T3 tumor, the patient receives neoadjuvant therapy, and it might be followed by either conservative or mastectomy according to the response. But for a T4 tumor, unfortunately, the patient receives neoadjuvant therapy, but she has only the chance of mastectomy.
Have you assessed the contrast-enhanced spectrum mammography role in T staging of breast cancer? And what about its accuracy?
Yes, according to one of the earliest studies, which was performed by Lobis et al., they compared the sizes of the lesions in contrast mammography and in MRI and in the postoperative pathology, and there was a significant correlation between the sizes of the tumors measured in both modalities and the postoperative pathology. In our department, we also performed a study comparing the size of the measured tumor in mammography, in contrast, and MRI, and we find a significant correlation also in contrast mammography and MRI, but the results were slightly higher for MRI because of the presence of some speculated mass lesions and lesions with intraductal extension, which might in some cases be underestimated in contrast-enhanced mammography.
Okay, Rasha, I will confirm what you have just said by this example. This is a contrast-enhanced mammography, and this is a mammogram, and this is tomosynthesis. I want you to compare the size of this tumor mass in both contrast mammography, in mammography, and in tomosynthesis. What do you think?
Definitely, the size measured in tomosynthesis is much larger than that in the mammography and the contrast mammography.
This is a case of a palpable left breast mass lesion, which is increasing in size. The mammogram revealed multiple adjacent obscured mass lesions, and with the ultrasound, complementary ultrasound revealed fibrocystic mammary changes but there was a speculated mass which was not detected on the mammogram. So we have to go for contrast enhanced mammography.
Yes, I think that's right, Dr. Ma, because a surgeon will never believe the discrepancy between what he sees with his hand and what we see.
So you
on
think
the
that
ultrasound.
contrast mammography is essentially in this case. So we did the contrast mammography and it revealed heterogeneously enhanced speculated mass, and which is and also the complicated cysts. And so the contrast mammography was only the procedure that we can measure the actual size of the mass and confidently say that it is a T1 tumor patient.
Yes, yes, I think so.
I'll
Yes.
show you another case of a patient with a pathologically proved invasive duct carcinoma. And the mammogram, from this mammogram, can you tell the actual tumor size?
No, I would ask for a contrast study because based on the mammogram, I can never see the actual.
So we did a contrast mammography, and again, the contrast mammography was the only procedure that can confidently say that it is a T3 tumor mass.
Yes, and now we move to assessment of the lesion extension. And when speaking of extension, it's not about the tumor size, it's about the relation of this tumor to the skin, to the nipple, and to the chest wall. And actually, we have to define how far the lesion is from these structures and whether there is actual invasion or not. Because only based on this information can the surgeon say whether the patient can take a neoadjuvant or upfront surgery, whether she can perform a conserving wrist surgery or mastectomy, if she is feasible for a skin-sparing mastectomy or no, or if she can perform central quadrantectomy or not.
Okay, Rasha. This is a 38-year-old female with a palpable right breast mass lesion, which was pathologically proved as invasive lobular carcinoma. And the mammogram revealed this single mass lesion. And so, according to this mammogram, this patient is a good candidate for conservative surgery. Do you agree?
No, I disagree with you, Dr. Never in such a type of breast would I depend on, even on the ultrasound, I would not depend. I need to perform a contrast.
We did the contrast mammogram, and what do you see?
There's a much wider extension of the lesion on the contrast mammography. And I think in this case, mastectomy is the only solution. But she's young, Dr. Ma, she's 38 years old. Does she have a chance to perform skin-sparing mastectomy?
No, I don't think, Rasha, because the tumor lesions are seen extending into the subcutaneous fat and reaching the skin. So this is not a candidate for nipple sparing, and mastectomy was the only
solution for her. Yes.
For her. This 40-year-old female with history of left skin sparing mastectomy and implant fixation. The annual mammogram for the right breast showed dense breast and multiple small nodular lesions. But with the ultrasound, it revealed multiple hypoechoic masses.
I'd like to perform a contrast mammography.
Yes, we did the contrast mammography, and we can see a multicenteric lesion. But according to this mammogram, right-sided skin-sparing operation was visible because the lesions are not invading the skin or the subcutaneous.
Yes, I think it was mandatory to perform.
Yes, I agree. In this patient with a palpable tiny right upper outer quadrant mass lesion, it was a T1 lesion, and it was a candidate for conservative surgery. But with the contrast mammography, skin infiltration is very obvious. So it is not a T1 tumor mass, but it is a T4B lesion. And also there were multiple lesions seen in close relation to the nipple. So this was a multicenteric lesion, and the patient underwent mastectomy and plus or minus neoadjuvant chemotherapy. This was confirmed by ultrasound examination. Patient presented by bleeding per right nipple, and this is the contrast mammography. What do you think about this contrast mammography, Rasha?
I think I can say it's normal with an increased parenchymal enhancement, but maybe the parenchyma is slightly higher, the enhancement is slightly higher on the right outer quadrant than it is on the left side.
Yes, I want to show you the the mammogram of this patient. What do you think about this mammogram?
There are multiple group microcalcifications. I think they look suspicious.
Yes, of course. This is suspicious microcalcification and confirm, follow the same distribution of the enhancement in the contrast mammography, and this was confirmed by ultrasound showing multiple intraductal lesions.
I would expect the pathology to be a low-grade tumor.
Yes, because the low-grade ductal carcinoma in situ are very faintly enhanced on the contrast mammography. This is a patient with a palpable right breast mass lesion, and the mammogram was very dense. With the ultrasound revealed a speculated mass, which is very deeply seated in the right lower inner quadrant at the inframammary fold. No enhancement was detected on the contrast mammography, but with the MRI, an rim enhancing speculated mass was seen deeply seated in the breast. So it was not detected by the contrast mammography because of the position of this mass.
So we can sum up by saying that contrast mammography is excellent in extension. With a few exceptions, whenever we have a multi-speculated lesions, we would expect that in some cases it might be underestimating the size. Lesions in mammography hidden areas cannot be assessed using contrast mammography, like deeply seated inframammary fold lesions, upper inner quadrant, axillary tail, unless the patient is very well positioned, we can miss these lesions. And some pathologies might be missed as normal background enhancement, like the low-grade DCIS and the lobular carcinoma, and they have to be assessed in relation to the clinical condition of the patient and in relation to her mammography.
And also to the ultrasound.
Yes. And now we move to assessing the lesion multiplicity. And when speaking of multiplicity, you can classify lesions into single lesions, bilateral lesions, multifocal lesions in the same quadrant, or multicentric lesions in two different quadrants or more than 5 centimeters apart. And for the single, bilateral, and multifocal lesions, the patient can undergo conservative surgery according to the tumor size and extension. But for multicentric disease, the patient only takes a chance or must.
This is a right breast pathologically proved invasive lobular carcinoma, and the mammogram revealed the right breast malignant or speculated lesion and left breast focal asymmetry. With the contrast mammography, multiple masses, the bilateral malignant looking breast lesions are seen with the small nodule, enhancing nodules seen around that. And this was a case of a bilateral multifocal malignant mass lesion, which was confirmed by the ultrasound. Left breast palpable mass lesion, and with the tomosynthesis revealed, confirmed the presence of this mass. But with the ultrasound revealed a tiny right retroareolar lesion, which was not seen on the mammogram or on the tomosynthesis. With the contrast mammography, the left breast lesion is not a single lesion. There were other multiple tiny enhancing lesions seen around it, in addition to the enhancing tiny right retroareolar region, and this was proved to be a bilateral invasive duct carcinoma. Screening mammogram of a 57-year-old female showing a malignant lesion in the lower inner quadrant of the breast and query upper outer quadrant tiny lesion. With the tomosynthesis, the nature of the does not confirm the malignant nature of this lesion. With the artificial intelligence, showed that showed the two lesions in the upper and the lower quadrant, but with the contrast mammography there were multiple enhancing lesions in the breast, and this was a case of a multicentric invasive cancer. In this case, the contrast mammography has the upper hand in detecting multiplicity. A screening mammogram of a 57-year-old female showing left paraareolar malignant mass lesion infiltrating the nipple. With the contrast mammography, the mass is much smaller than seen in the mammogram, and there is another enhancing suspicious lesion in the upper outer quadrant of the breast. This was exactly seen on the MRI, showing the two malignant lesions, and this was a case of a multicenteric invasive duct carcinoma. Screening mammogram of 40-year-old female showing the mammogram revealed heterogeneous dense breast, no lesion was detected. This was considered or categorized as BI-RADS 0, and the patient was recalled for ultrasound. Automated breast ultrasound was carried for this patient, showing multiple irregular hypoechoic masses. But with the contrast mammography, there were multiple enhancing foci in the right breast, confirming
I think Dr. No, this was essential for the surgeon.
Yes, yes, of course. And this was proved to be a multicenteric invasive lobular carcinoma.
Dr. No, can you use contrast mammography to exclude multiplicity? Like it confirms,
yes, I will show you some example. This is a patient with left palpable breast mass lesion, and the left breast showed a 12 o'clock speculated mass lesion confirmed by ultrasound. And but there were other multiple tiny enhancing tiny bilateral hypoechoic nodules with the PEM showed the left breast mass lesion and other lesions, small lesions in the left breast.
They look malignant?
We can consider them malignant, but we have to do a contrast mammography. What do you think about the contrast mammography?
No, on the contrast mammography, I don't see they are malignant. These are multiple bilateral symmetrical enhancing foci, and according to the BI-RADS lexicon, they should be considered as part of the background.
Yes, you are right. And the pathology revealed the left breast malignant mass and right adenotic nodules and papillomas.
And now we come to the last station, which is the lymph nodes. The regional lymph nodes of the breast are classified into the axillary nodes, the internal mammary nodes, and the supraclavicular node. We say we have an NX tumor when the lymph nodes cannot be assessed, and 0, the cancer has not spread to the lymph nodes, and 1, cancer has spread to either the axillary, the internal mammary, or both. And 2 tumors are amalgamated fixed axillary nodes or remarkably enlarged internal mammary nodes. And N3 nodes are tumors which have spread to the infraclavicular or supraclavicular nodes. Lymph node staging is a fundamental step in the preoperative staging of patients with newly diagnosed invasive breast cancer. Preoperative imaging of the axilla plays an imperative role in clinical staging, and up to now, ultrasound is the gold standard technique in assessing the axilla. In contrast imaging, all nodes, whether normal or pathological, show contrast uptake. Pathological nodes may show marked enlargement, globular in shape, cortical thickening, muffled hyla, and heterogeneous enhancement. In contrast mammography, unfortunately, we can only assess level 1 lymph nodes, while in other cross-sectional contrast imaging like CT or MRI, we can assess all lymph node groups. This is an example to show you the difference between an enlarged but non-specific lymph nodes with a preserved hilum and an enlarged pathological lymph nodes with a muffled or hilum or marked cortical thickening. And these are 4 other examples showing amalgamated axillary and intramammary lymph nodes.
Okay, this is a case of a right upper outer quadrant biopsy proved malignant mass lesion and query intraductal component. But this intraductal extension was confirmed by both contrast mammography and MRI. But MRI was superior in detecting the pathologically metastatic axillary lymph node.
And to sum up what we've said, in local staging, assessing the size, extension, and multiplicity, contrast mammography is considered an excellent tool with few exceptions in the mammography hidden areas and with some few pathologies. Well, unfortunately, in lymph node stages, it is not the modality of choice because we can only see level 1 lymph node, and we should do a complementary ultrasound to assess the rest of the lymph nodes.
Thank you. Thank you.